Okay, let's unpack this. Welcome to a new deep dive. Today, we're diving deep into a really serious, often devastating topic in veterinary medicine, septic shock in animals.
Yeah, it's definitely one of the most critical emergencies we face. It requires immediate, really aggressive action. Understanding it isn't just, academic, it's often life or death for the patient.
Exactly. And to guide us through this, we pulled together a stack of sources, insights distilled from texts like septic shock in animals, pathophysiology to treatment, and septic shock in veterinary patients.
Good sources.
Our mission today is to take these complex bits of information and, well, make sense of them for you. What is septic shock, really? Why does the body go into this kind of tailspin? How do you even spot it? And what's the game plan to try and pull a patient back from the brink?
Yeah, what can actually be done?
We're aiming to find the core insights, maybe even some surprising facts buried in the details.
Think of it as getting the essential intelligence, the key info you need on this multifaceted crisis happening inside the body.
Okay, so let's start with the fundamental definition. When we talk about septic shock, what are we actually talking about at its core?
Well, at its core, septic shock is the most severe life-threatening form of sepsis. And the defining feature, the clinical signal that really puts it in the shock category, is persistent low blood pressure hypotension that just sort of hangs around even after you've given what should be an adequate amount of fluid resuscitation.
Okay, so you've given fluids, you're trying to boost that pressure up, and it's not responding.
Yeah.
Still dangerously low.
Precisely. It means the blood pressure is so unstable that the body now requires medication, specifically vasopressors, drugs that help tighten blood vessels, just to maintain some level of pressure.
Right.
It's not just low pressure, it's low pressure caused by a profound breakdown in, well, circulation, how cells function, and the body's metabolism, and the outcome. It's often grim. It carries a very high risk of death in veterinary patients.
That high mortality rate immediately tells you the gravity of the situation. Our sources highlight that clinical recognition often means needing those vasopressors to keep the mean arterial pressure, the MAP, above 65 millimole Hg, or the systolic pressure above 90, despite fluids. And usually you'll see elevated lactate levels alongside that.
Yeah, that elevated lactate is a critical red flag. Levels often climb above 2.5 millimoles per liter. It's basically a marker screaming that tissues aren't getting enough oxygen and the cells are switching to a less efficient, kind of desperate form of energy production.
Leading to lactic acid buildup.
Exact.
Got it. So it's not just an infection. It's like a complete systemic failure initiated by an infection. Where does septic shock fit into the broader picture of, infection gone wrong? Is it the start, the middle, or the end?
It's definitely toward the end, or at least the peak, of a really dangerous progression. It can start simply maybe with just bacteria in the bloodstream, that's bacteremia.
Okay.
That can trigger a generalized inflammatory response throughout the body, what we call SIRS, or systemic inflammatory response syndrome.
And SIRS itself isn't always caused by infection, right?
Yeah.
Like trauma can cause SIRS.
That's absolutely right. SIRS is the body's sort of generalized alarm system. But when SIRS is clearly linked to a suspected or confirmed infection and it starts causing specific organ systems to malfunction, that's when we call it sepsis.
Okay.
There used to be a middle category, severe sepsis, but the focus now is kind of shifting. Sepsis is the point where infection plus the body's dysregulated response causes organ dysfunction.
Okay, so infection plus an out-of-control alarm
Right.
plus organ trouble
Yeah.
equals sepsis. And if that spiral continues,
Right. If
Yeah.
that septic state progresses to the point where the circulatory and cellular problems are so severe that blood pressure remains dangerously low despite getting fluids, and you need those vasopressor medications to prop it up, that's septic shock.
okay.
And sadly, if multiple organ systems start to fail due to this relentless attack, that's multi-organ dysfunction syndrome, or MODS. It's really a worsening chain reaction.
Wow. So it's the body's response to the infection that becomes the engine of destruction here. Where do these infections typically start to kick off such a disaster?
Well, any localized infection can potentially trigger this cascade, especially if it's severe or, the patient is vulnerable.
Yeah.
Our sources point to common culprits. Often it's bacteria, particularly gram-negative ones like E. coli, Klebsiella, because they release potent toxins like endotoxin.
Okay.
But gram-positive bacteria like staph infection, strep, they're also major players due to their own toxins and cell wall components.
And are there certain hot spots in the body where this tends to originate? Like common starting points.
Absolutely. The abdomen is a really frequent source. Think peritonitis from maybe a ruptured organ or a pyometra. That's a severe uterine infection in female dogs.
Right.
Serious urinary tract infections, especially if they spread up to the kidneys, pyelonephritis, deep-seated pneumonias, or pus in the chest cavity, pyothorax, nasty skin infections, abscesses, septic arthritis in joints, even infections on heart valves, endocarditis.
And you mentioned iatrogenic sources from the sources. What's that?
Yes, that refers to infections that can unfortunately arise from medical procedures or devices themselves, like infected IV catheters, maybe implants, or surgical site infections, things we introduce, basically.
Gotcha. Are some animals just set up to be more susceptible to this kind of catastrophic response?
Yeah.
What puts them at higher risk of an infection escalating all the way to septic shock?
Definitely. Our sources highlight factors that compromise the immune system. The very young and the very old are classic examples. Animals already dealing with diseases that suppress their immunity, things like FeLV5 in cats, parvovirus in puppies, endocrine diseases like diabetes or Cushing's, or those on immunosuppressive medications like chemotherapy or steroids.
So if they're already fighting something else or their immune system is weakened, they're kind of on thin ice already.
Yeah. Exactly. Severe existing illness, the presence of indwelling medical devices like catheters, delays in recognizing or treating the initial infection, prior antibiotic exposure, which can sometimes select for tougher bacteria, and major traumas, burns, or complex surgeries also increase the risk.
It really sounds like the body's control systems just break down completely. Can we peel back the layers a bit on how this happens?
Yes.
This dysregulated host response seems like the central villain here.
Okay, yeah, this is where it gets really interesting and complex, but let's try and break it down. Imagine the body has this incredibly sophisticated but also very sensitive alarm system that's the innate immune system.
Okay.
When an infection hits, pathogens or even damaged body cells trigger this system using various signals, PAMs and DAMPs, activating receptors like TLRs. Think of it like pulling a fire alarm.
Okay, the alarm is pulled, now what?
Right. And that alarm triggers a massive, really urgent release of signaling chemicals, inflammatory mediators like TNF-alpha, various interleukins, nitric oxide, things like that. In a healthy response, this is controlled, targeted, and helps fight the infection.
But not in sepsis.
But in sepsis, this system goes completely haywire. It's like the fire alarm doesn't just ring, it sets off every sprinkler, every strobe light, and every siren in the entire building all at once, everywhere, totally uncontrollably. This initial overwhelming inflammation is the SIRS component.
So the response itself becomes destructive. It's friendly fire, essentially.
Precisely. And this widespread chemical storm causes chaos on several fronts. First, the vascular system. Those excessive signaling chemicals, especially nitric oxide, cause profound relaxation of the blood vessels. They become way too wide everywhere. Systemic vasodilation.
Wide vessels means the blood pressure drops, right?
Oh, yes.
That's the hypotension we talked about earlier.
Yes, exactly. That's the distributive shock component. The container for the blood just got way too big. But it gets worse. The inflammation also damages the delicate lining of the blood vessels, the endothelium, making them incredibly leaky.
Leaky? How?
Think of the protective layer inside the vessels getting sort of stripped away or damaged.
Like a leaky garden hose. Or maybe a sieve.
Exactly, or like trying to fill a leaky bucket. Fluid, electrolytes, even vital proteins like albumin that should stay in the bloodstream start leaking out into the surrounding tissues.
So the animal gets swollen everywhere. That's edema.
Yes, that generalized swelling or edema. And this leakage is what we call third spacing. The fluid is still in the body, technically, but it's no longer inside the blood vessels where it can circulate effectively and, maintain blood pressure. So you end up with absolute hypovolemia, a low effective blood volume, even if you're pouring fluids into the patient intravenously, because a lot of it just leaks right back out of the circulation.
Wow, okay, that explains why just giving fluids isn't enough. The container is both too big and leaky.
Correct. And the problems extend down to the tiniest vessels, the microcirculation. Blood flow there becomes erratic. You get traffic jams in some areas, weird detours in others, some areas completely blocked. Oxygen can't get from the blood into the cells properly, even if there seems to be enough oxygen circulating in the main vessels.
Blocked by what? Just swelling?
Partly, but also tiny clots. That uncontrolled inflammatory response also activates the body's clotting system. It goes into overdrive, forming microscopic clots, microthrombi everywhere. At the same time, the system that normally breaks down clots, fibrinolysis, is often impaired.
Oh, wow.
So the body is in a procoagulant state, making clots and potentially using up its clotting factors, which can lead to this terrifying state called DIC, disseminated intravascular coagulation, where they are paradoxically clotting and bleeding.
That sounds like the body's just completely dismantling itself from the inside out.
It truly can feel that way sometimes. Then you go down to the cellular level and there's energy failure. The low oxygen delivery, combined with the direct effects of those inflammatory chemicals, damages the cell's power plants, the mitochondria.
Okay.
Cells are forced to switch to a much less efficient way of making energy, anaerobic metabolism, which produces that lactic acid we talked about.
Ah, so the elevated lactate ties right back into this cellular energy crisis.
Exactly. It reflects this desperate state. Cells are basically starving for energy, and even if oxygen is delivered, they sometimes struggle to use it effectively. A concept sometimes called cytopathic hypoxia, the internal machinery is broken.
What about the heart in all this chaos? Does it keep pumping okay?
Unfortunately, the heart isn't spared either. Those same inflammatory mediators can directly weaken the heart muscle itself, leading to something called septic cardiomyopathy. The heart just can't pump blood as strongly, reducing cardiac output and worsening that whole cycle of poor perfusion. Arrhythmias, irregular heartbeats, are also very common.
So let me get this straight. The vessels are leaky and wide, there are microscopic clots everywhere, cells can't make energy properly or use oxygen well, and the heart itself is weakened. It's like every single part of the circulatory and cellular system is under simultaneous attack.
That's the devastating complexity of it, yes. And just when you think it couldn't possibly get worse, there's another layer: immune dysregulation. After that initial overwhelming inflammatory storm, the SIRS phase, the body tries to put on the brakes with an anti-inflammatory response called CARS.
Compensatory anti-inflammatory response syndrome. It tries to calm things down.
Yes, it tries to counterbalance. But this can swing too far the other way, leading to a state of immunoparalysis or immune suppression. The immune system, after going into hyperdrive, essentially becomes exhausted and suppressed. Key immune cells like T cells and monocytes don't function properly anymore.
So after fighting too hard initially, it becomes weak and vulnerable later.
Exactly. This leaves the patient wide open to picking up secondary infections, including dangerous ones they might encounter in the hospital environment. It's a really cruel twist.
Oh.
All these cascading failures, the low pressure, the poor oxygen delivery, the energy crisis, the clotting, the immune collapse, they build on each other, leading ultimately to the progressive breakdown of multiple organ systems. MODS.
Which organs are usually the first to show the strain or, fail in MODS?
Our sources commonly list the kidneys, leading to acute kidney injury or AKI, the lungs, causing something like ARDS, acute respiratory distress syndrome, which is severe respiratory failure, the liver, the brain, leading to encephalopathy, so confusion or coma, and the gastrointestinal tract is also very susceptible.
It sounds like the body is just coming apart at the seams. Given all this happening internally, what does an animal in septic shock actually look like on the outside? What are the clinical signs you'd see?
Well, the signs are incredibly variable and dynamic, really reflecting which part of this chaotic cascade is dominant at that moment. And this is one of those areas where you see some surprising differences between dogs and cats. Our sources describe two main presentations, generally speaking.
Okay, tell me about those differences. That seems really important for recognition.
First, there's the hyperdynamic or warm shock phase. This is actually more often seen in dogs, particularly in the early stages, and these patients might look deceptively robust initially.
Really? Robust?
Yeah, they can have bright brick red mucous membranes, like really red gums, and a capillary refill time that's super fast, less than a second.
So you press their gums, they turn white and snap back to red almost instantly.
Right. Their pulses can feel strong, maybe even bounding. They're often tachycardic heart rate, usually over 120 in dogs, and might have a fever and warm extremities. Mentation might even be alert or anxious before it starts to deteriorate. And interestingly, their blood pressure might appear normal or even high initially, before it inevitably crashes later.
That's the really surprising part for me. Shock makes me think weak and cold, but they can initially look hot and strong, especially dogs.
Exactly. It's that initial massive vasodilation and the heart trying to compensate by pumping harder that gives that temporary warm appearance. But then there's the other side, the hypodynamic or cold shock phase. This is the more classic presentation we often think of with shock, and it's much more common in cats, or what dogs look like in later, more severe stages.
And that sounds more like what I'd instinctively expect from shock.
Yes. These animals typically have pale, maybe muddy, or even bluish cyanotic gums. Their capillary refill time is prolonged, often over 2 seconds. Pulses are weak, thready, sometimes hard to even find. They're often hyperthermic low body temperature, which is a really grave sign, especially in cats. Their extremities feel cold, and their mentation is usually depressed, dull, unresponsive, or even comatose. In this phase, the blood pressure is overtly low.
And a critical difference you mentioned before, heart rate. That stood out.
Yes, while dogs are usually tachycardic initially, cats in hyperdynamic shock are often bradycardic, a dangerously low heart rate. Seeing bradycardia in a shocked cat is a major, major red flag. In dogs, profound bradycardia usually means they are severely decompensated and basically crashing.
So dogs might start hot and fast, then progress to cold, and potentially slow later on, while cats often seem to jump straight to cold, slow, and weak. That's a huge distinction for recognition, isn't it?
It really is. It makes early recognition in cats sometimes trickier. Other signs reflecting organ dysfunction can include rapid or difficult breathing, very low or even no urine output, signs specific to the infection site. And if DIC is happening, you might see bruising or tiny pinpoint hemorrhages, petechiae on the gums or skin.
Okay, so the clinical signs give you a strong suspicion. How do you actually go about confirming septic shock? What's the diagnostic approach?
Well, our sources emphasize it's really a continuous assessment process. It starts with recognizing those clinical signs of shock, the poor perfusion parameters we just talked about. Then you see if the animal meets the criteria for SIRS, plus you have a suspected or confirmed source of infection. That combination points towards sepsis.
Right.
The final step to calling it septic shock is demonstrating that persistent hypotension despite adequate fluid therapy. That's the key differentiator.
So you use those SIRS criteria, like the specific numbers for temperature, heart rate, respiratory rate, white blood cell count as part of the puzzle?
Yes, exactly.
Right.
The sources provide specific values for those parameters in dogs and cats to help formally identify SIRS. But again, the key for shock is that blood pressure failing to respond properly to fluids, meaning it requires vasopressors.
What about blood tests and other diagnostics? What do they tell you?
Labs are absolutely essential for assessing the severity of the systemic damage. Elevated blood lactate, that level, typically 2.5 millimol, is really a cornerstone. It tells you how bad the tissue hypoperfusion is. And critically, serial lactate monitoring, watching if the level goes down over time with treatment, is a vital indicator of whether your therapy is working and carries significant prognostic weight.
So it's about the trend, not just a single number snapshot.
Exactly. The trend is key. Blood glucose is important, too often high initially due to stress hormones, but low blood sugar, hypoglycemia later on is a very poor prognostic sign. A complete blood count, the CBC, might show dramatically high or maybe very low white cells, often with evidence of cellular damage, what we call toxic changes. You often see low lymphocytes, indicating stress or immune suppression, and frequently low platelets, thrombocytopenia, hinting at potential clotting problems.
Like early signs of that DIC you mentioned.
Potentially, yes. Biochemistry panels can show organ damage, elevated kidney values, isotemia, high liver enzymes, bilirubin. Electrolyte imbalances are common, and often you see low protein, particularly albumin, which, as we said, worsens that leaky vessel problem. Coagulation tests can confirm clotting abnormalities, things like prolonged PT and PTT times, elevated D-dimers and FDPs, which show clot breakdown products, and depletion of natural anticoagulants like antithrombin. Blood gas analysis typically shows acid-base imbalances, often metabolic acidosis, and possibly low oxygen levels.
Wow, lots of pieces fitting together to paint a picture of systemic chaos. But the infection is the root cause, right? How do you find that in the middle of this crisis?
Yeah, identifying and controlling the infection source is just as vital as stabilizing the patient's circulation. It has to happen concurrently. Imaging is key here. Ultrasound is great for rapid assessment of body cavities, like the sources mentioned, quick FSD fast scans looking for free fluid. Traditional radiographs, x-rays, or even more advanced scans like CT might be needed if the patient is stable enough.
Looking for collections of pus or fluid or abnormal organs.
Yes, exactly. And samples from any suspicious sites are critical cytology and fluid analysis from abdominal or chest effusions, joint fluid, abscesses. Urinalysis and urine culture are standard. Blood culture is considered the best way to confirm bacteria are spreading via the bloodstream. Ideally, you take samples aseptically before starting antibiotics. But the sources are very clear. Do not delay giving antibiotics just to get cultures. Time is absolutely critical.
Got it. Antibiotics first, cultures if possible, without delay.
Right. And cultures with sensitivity testing from any suspected source wounds, drains, body fluids are crucial to guide definitive antibiotic therapy later on.
So it's a race against time. Diagnose the systemic crisis and find where it all started. Once you've got this diagnosis, or a very strong suspicion, what's the intense treatment strategy look like?
The treatment is aggressive, it's goal-directed, and it absolutely requires intensive critical care, usually in an ICU setting. The sources really highlight the concept of the golden hour, maybe the first 1 to 6 hours, as absolutely crucial for getting key interventions started.
Okay, the golden hour. What are the absolute top priorities in that window?
Immediate priorities are establishing vascular access, often multiple large-bore IV catheters, or sometimes even access into the bone marrow, intraosseous, or IO access for fluids and medications. Then, maximizing oxygen delivery, giving 100% oxygen through various means, and addressing severe anemia if the red blood cell count, the PCV, is dangerously low, say below 25%.
In fluids, is it just pouring fluids in as fast as possible?
Fluid resuscitation is next, but it's goal-directed fluid therapy, or GDFT. The aim is definitely to support the circulation and improve oxygen delivery, but you have to be incredibly careful, especially in cats, as we mentioned, to avoid fluid overload, which can easily worsen lung problems like pulmonary edema.
So how do you do it carefully?
You typically use rapid boluses of intravenous fluids, usually balanced isotonic crystalloids like LRS or Normasol R. You give a measured amount, maybe 10-20 millokg for dogs, or a more cautious 5-10 millokg for cats, over maybe 15-20 minutes, and then you immediately reassess the patient's perfusion parameters.
So small amounts check, like a titration.
Exactly, titrating the fluids to the patient's response. Are their heart rate, pulse quality, gum color, CRT improving? Crucially, is their lactate starting to trend downwards? Those are your guides. You also look for signs of overload. If blood pressure remains dangerously low despite maybe improving other perfusion parameters with fluids, or if giving more fluids seems risky because of potential overload, that's when you escalate to vasopressor medication.
The drugs to tighten the vessels back up.
Yes. Norepinephrine is often the first choice, the go-to. It helps constrict vessels, raising blood pressure, and it has some positive effect on heart contractility. Vasopressin is another powerful vasopressor, often added if norepinephrine alone isn't quite enough.
Are there others?
Yeah, there are others, like dopamine, but it's maybe less commonly used first line now due to potential side effects. For patients where a weak heart, that septic cardiomyopathy seems like a major part of the problem, a drug like dobutamine, which primarily helps the heart muscle pump better, might be considered. Though you have to use it very cautiously in cats, as it can cause seizures at higher doses. And with all these, you're constantly monitoring for side effects like irregular heartbeats or excessive constriction that could harm tissues.
Okay, so fluids first, carefully titrated. If that's not enough to get blood pressure up, add vasopressors like norepinephrine. What about the source of the infection itself? Antibiotics.
Absolutely crucial, and early is the key word. Broad-spectrum intravenous antibiotics should be given as soon as possible, ideally within that first hour of recognizing sepsis or septic shock. While getting cultures first is ideal, the sources emphatically state, do not delay giving those initial antibiotics to wait for cultures. You hit it hard and fast based on the most likely culprits for the suspected infection source, then you narrow the antibiotics later based on culture results when they come back.
So empiric broad spectrum initially to get specific once you know the bug, and physically addressing the source, the surgery part you mentioned.
Yes, timely source control is often non-negotiable and frequently the only way the septic shock will ultimately resolve. This means things like surgically draining abscesses, removing dead or infected tissue, debridement, taking out infected foreign bodies like implants, or repairing ruptured organs that are leaking infection into the body. The sources really stress that even if the patient is critically unstable, not delaying necessary surgery can be detrimental because that ongoing infection source just keeps fueling the fire of the shock state.
Wow. So it's a massive, urgent, multi-front battle. Fluids, vasopressors, broad antibiotics, and often surgery, all happening simultaneously or in very rapid succession. What does the intensive care involve after that initial push? It sounds exhausting.
It is. It's constant, meticulous monitoring and support 24/7. Blood pressure, ideally measured directly with an arterial line for real-time accuracy, continuous ECG for heart rhythm, pulse oximetry for oxygen levels, maybe capnography for CO2. Monitoring central venous pressure might give some fluid status clues, tracking urine output literally minute by minute or hour by hour, continuous temperature monitoring, repeating lactate and glucose levels frequently, checking electrolytes, acid-base balance, and coagulation status regularly.
Every single drop of fluid in and out is measured.
Pretty much meticulous fluid balance is key. You're constantly walking that tightrope, trying to avoid both fluid overload and dehydration.
Keeping them stable on a real razor's edge.
Exactly. Managing blood sugar, correcting dangerously low glucose with IV sugar solutions, dextro-CRI, but probably not aggressively treating high glucose unless it's extreme, as that sometimes can worsen outcomes. Protecting the gut with anti-nausea and anti-acid medications is important, and getting nutrition into them early, often via a feeding tube placed directly into the stomach or intestine. This is really crucial for maintaining gut health and preventing bacteria from leaking out. Translocation.
What if they can't tolerate gut feeding?
Then parenteral nutrition, IV feeding might be needed, but enteral into the gut is preferred if possible. Respiratory support is key too, which might just be oxygen or could mean full mechanical ventilation if their lungs are failing, ARDS. Renal support for kidney injury, maybe trying to encourage urine production or even dialysis in severe cases, and managing those clotting abnormalities, DIC, with transfusions like plasma or maybe specific factors, though some treatments like heparin are controversial.
Pain management must be vital too. They must be incredibly uncomfortable.
Absolutely vital. Using strong PRIN medications like opioid infusions, often fentanyl CRI, to keep them comfortable and minimize stress and oxygen consumption. And of course, strict hygiene is paramount to prevent those secondary hospital-acquired infections, which they are now extremely vulnerable to because of that potential immunoparalysis we discussed.
Right. You mentioned immune modulation strategies, like steroids.
Yeah, the sources mention things like immune modulation, potentially using corticosteroids, but they note this is quite controversial in veterinary medicine and generally not recommended routinely for septic shock unless specific conditions, like documented relative adrenal insufficiency, are suspected after testing. It's an area where more research is definitely needed, maybe targeting specific pathways or trying to reverse that immunoparalysis.
Okay. Given how incredibly complex and aggressive the treatment is, what are the actual chances? What's the prognosis for an animal that develops septic shock?
Yeah, this is the tough part. Our sources are very clear. The prognosis is generally guarded to poor. Despite all the advances in critical care, mortality rates remain distressingly high, often reported somewhere between 40% and maybe 80% or even higher, depending heavily on the underlying cause and the individual patient.
Those are really tough odds. What factors might make survival more likely? Are there any positive signs to look for?
Well, positive indicators include catching it very early, getting definitive control of the infection source quickly, that surgery or drainage we talked about, seeing a rapid improvement in the patient's clinical condition and perfusion parameters with the initial fluids and vasopressors, especially seeing those lactate levels come down quickly. That lactate clearance is huge. Maintaining normal glucose levels is generally better than having high or low. And critically, not developing failure in multiple organ systems, MODS.
And the really bad signs, the negative prognostic indicators.
Things like delayed diagnosis or treatment, having an infection source that simply can't be controlled, persistent low blood pressure and high lactate despite aggressive treatment, developing hypothermia, low body temperature, profoundly low blood sugar, hyperglycemia, severe drops in white blood cells, leukopenia or platelets, and definitely the onset of MODS. Ultimately, the outcome depends hugely on why they became septic in the first place and how quickly and effectively that initial cause and the resulting systemic crisis can be addressed.
We highlighted the difference in clinical signs between dogs and cats earlier, the warm versus cold shock. Are there other important comparative aspects between the species?
Yes, definitely. Beyond that typical hyperdynamic versus hypodynamic presentation, dogs often presenting warm and tachycardic initially, cats often cold and bradycardic. Fluid tolerance is a really important practical one to remember. Cats are generally much less tolerant of aggressive fluid volumes and are significantly more prone to developing fluid overload and pulmonary edema, fluid in the lungs.
So you have to be even more cautious and meticulous with fluid boluses and rates in cats.
Absolutely, even more so than in dogs. And yes, that bradycardia in shock is a much more significant and common warning sign in cats. In dogs, bradycardia in shock usually means they are in very, very grave condition, near arrest. There's also some thought or observation that while septic shock affects the whole body, the GI tract is often considered a primary shock organ in dogs, meaning it takes a big hit early, whereas the lungs, leading to ARDS, and the kidneys seem particularly highly susceptible in cats.
Fascinating. These species, differences in how they respond to the same fundamental crisis. Can you actually prevent septic shock from happening in the first place?
Well, preventing an infection from escalating all the way to septic shock once it's already established and causing sepsis is very difficult. The real focus is more on early recognition and aggressive treatment of sepsis to try and prevent it from progressing to shock. More broadly, general prevention involves things like prompt and effective treatment of wounds and infections when they first occur, proper surgical technique, and using antibiotics judiciously and appropriately to avoid creating resistant infections.
And what are some of the potential complications, even if a patient manages to survive the initial acute shock phase? Are they out of the woods?
Unfortunately, not always. They can face a whole host of ongoing issues. Persistent problems from those leaky vessels like fluid overload or swelling in tissues. Ongoing issues with blood sugar control, anemia, low platelets, or coagulation disorders lingering. And certainly the continued risk or consequences of multiple organ dysfunction affecting the heart, lungs, kidneys, liver, gut, pancreas, adrenal glands, or even the brain. And cardiac arrest, sadly, remains a possibility throughout the hospitalization in such fragile patients.
It truly sounds like a massive battle with potentially long-lasting consequences, even for the survivors.
It absolutely is. It takes a huge toll on the body.
So what does all this mean for you, the listener, thinking about this incredibly complex condition? We've really seen how a seemingly contained infection can just unleash this devastating cascade where the body's own defense system turns destructive, causing chaos in blood vessels, cells, organs, and even leading to this weird state of immune collapse later on.
Yeah, I think what really stands out here is the incredible, almost unbelievable delicacy of the body's internal balance. The very system designed to protect us, the immune system, can, when it gets dysregulated, become the actual engine driving this multi-systemic failure. Understanding septic shock is really understanding just how easily that vital balance can be lost when the body faces a severe insult, like a major systemic infection. It's such a stark reminder of the profound interconnectedness of all those bodily systems we've been talking about.
That interconnectedness is powerful, isn't it? And thinking about that whole cascade, especially the way the immune system can become suppressed after the initial inflammatory storm, it really raises an interesting question, I think. Given this profound state of immunoparalysis that can follow the initial chaos in septic shock, which leaves patients really vulnerable to new infections, how might veterinary medicine, or medicine in general, truly balance saving the patient from that immediate life-threatening shock versus protecting them from entirely separate, potentially deadly infections they might pick up while their immune system is essentially offline?
That's a fundamental challenge in critical care, isn't it? And definitely an area of ongoing research. How do you effectively dampen that initial destructive storm without completely disabling the defenses needed for the next threat that might be lurking? It's a very fine line to walk.
It really is. A tough balancing act. Well, that was certainly a deep dive into a challenging and absolutely critical topic. We hope this unpack of the sources on septic shock in animals gave you a clearer picture of what's happening inside the body and why it's such a profound emergency. Thank you so much for joining us.
Always valuable to explore these critical conditions in depth. Thanks for the discussion.
Agreed. Thanks everyone for listening.